very excited to introduce you to our latest webinar, which will be presented by Mr. Sherif El-Tawil, consultant orthopedic surgeon, all about knee and hip imaging. Excited to do this as well in conjunction with Rehab Guru. A lot of you here will obviously know who Rehab Guru are. And Simon will give a bit of intro in a little bit, but we worked with them for a long while, one of our earliest partners, and it's outside of being a great partner, it's been really exciting to see them grow as well over the couple of years. So yeah, really happy to be partnering with them on this one as well. But just by way of a quick intro, we're Scan.com. We are the UK's largest network for medical imaging. I'm Tom. I run the marketing team. I've been here 2022 from the get-go, or nearly the get-go. We actually were founded by an osteopath, who is our clinical director now, who essentially, through was seeing his patients and through the course of that care, was recommending they get scans. It was taking a little while on the NHS, and so he started using the independent capacity in the sites around him up in Nottingham, and really it just grew from there. So we now work with over 250 high quality centers around the country, essentially offering a point of entry or point of referral for MRIs, CTs, ultrasound, X-rays. Super simple to refer into us, especially if you're using Rehab Guru. We have the portal, we have an API, and referring takes minutes. We also vet referrals. We have an in-house team who vet referrals when they come into us. Yeah, it's super simple to use. There's a lot of you using it at the moment, and we hope, in the course of this, that you might check us out. And again, you can do that via Rehab Guru as well. But I will now just throw over to Simon, who will just tell you a little bit about Rehab Guru.
Thanks very much, Tom. Good evening, everybody. I'm Simon, co-founder of Rehab Guru. Really, I'm just going to spend 30 seconds cantering through this part, which is what Rehab Guru offers. So we're very, very proud of our partnership with Scan.com. And what we're really offering is the ability to try and bring everything into one platform. So that is seamless imaging referrals. And for those of you that maybe don't have an agreement with scanning organizations or have referral authority, there is that top cover from the experts at Scan.com. So it really does democratize the ability to send for imaging. The all-in-one platform, so that is all of your treatment notes, patient forms, exercise prescriptions, and imaging, all hosted in one secure platform. And the results from any imaging will again come into that single platform. So it keeps everything under one roof. You're not having to upload or scan in files to bring them into your medical notes. And our whole goal is to really simplify the clinician's workflow so that you can get back to doing exactly what you do best, which is patient facing, have more time to deliver better care and deliver outstanding patient experiences. And that's it from me. Back to you, Tom. Thank you.
Great. Thanks, Simon. Mr. Sherif El-Tawil, consultant orthopedic surgeon. So if you want to take it away, that'd be great.
Thanks so much, Tom. That's very kind. Thank you. So I'm just going to share my screen. So welcome, everybody. This is me, Sherif El-Tawil. These are details at the bottom, which obviously you can keep for the future if necessary, and feel free to approach me at any time if the questions in the future. I work basically as a consultant knee and hip surgeon at London Northwest University Healthcare Trust. I've been there for about 8 years now. I'm the lead for patient-related outcome measures after total knee and total hip replacement. And privately, I work at the Sign Clinic and also the Clementine Churchill in Harrow. So my interests are quite varied, actually. I do knee arthroplasty, I do revision, knee replacements, I do primary hip replacements, but my passion really is in ACL and meniscal surgery. So lots of ACL reconstructions, a lot of meniscal repairs, and cartilage preservation. So our population seems to have a lot of cartilage defects, which I try and fill in, especially in the pediatric population. So I'm very lucky to work with a great team and even great reps from companies. and obviously scon.com, which I'll come to. So this is the presentation content, why imaging matters, when to scan, when to escalate, and when to pause, how to choose the right scan. And mainly this is going to be case studies. So there's quite a few case studies to go through, and it'll be quite interactive. So the more people who speak out, the more people who write in the chat, the more it's going to be beneficial, I think, for you. So that's going to be the primary emphasis of the presentation is lots of case studies and hopefully lots of questions from the audience. So why does imaging matter? Well, obviously it refines diagnosis. So after the history and clinical examination, hopefully you've got quite a good idea as to what's going on. But obviously, imaging is going to be it has the final say in most of the time. And it's really important to avoid both under and over treatment. So many times, especially if you have difficult access to imaging. I mean, we're lucky in hospitals; we just literally send patient down the corridor. But if access is much more difficult, it's quite easy to undertreat. If you think you know what's going on, but actually after lots of conservative treatment, things aren't working out, then it's time to scan. But then equally, you don't want to overscan, because if you scan prematurely, it will confuse the picture, and often it won't be necessary. So there's definitely a balance to be struck. Scanning obviously gives clarity in complex or unclear cases, and this is something particularly at the complex side of things like osteotomies and joint replacement surgery, that we use CTs and various things, as you'll see in the case studies, to help in those complex cases. So the tipping points, when to scan. So obviously, if there's any red flags, you're not going to waste any time. You're going to order straight away the relevant scan. If, as I said, conservative management's not working and patient has persistent pain, then it's the right time to scan. And especially if there's anything in intra-articular where the patient may present with symptoms of locking in the knee or giving way, then there's something mechanical going on, and would need further imaging. When to escalate. So yes, failed conservative care. When you've got a patient who's got a ligament or meniscal rupture, and those patients that will require surgical planning. So those are actually relevant, not just when to scan, but also when to refer on to specialists like myself. And generally, myself and my colleagues are very happy to see patients that you're not sure about. So the threshold to refer, you shouldn't be too afraid to refer on if you're starting to have doubts about whether your management's going the right way. I went to pause. So this is equally important. Is you can get patients with lots of weird and wonderful signs and symptoms that aren't really specific to anything, and deep down this just doesn't fit with anything. Then it's absolutely fine to keep waiting and pause and continue with physiotherapy, other conservative measures. It's really when you know something is going on or something very specific is evident that you'd want to scan to prove the diagnosis. But when you just can't put your finger on it and it's very generic, you're probably right. Your clinical acumen is actually paramount in those cases. And I've had a recent case of a young girl who it was referred on to me by a physiotherapist, and they weren't sure what was going on, but patient was in severe agony, actually. We're not talking a little bit of pain, severe pain in the knee, and parents were obviously very concerned. Schooling was affected, even the exams were affected, and she had to repeat the year. So very organic, let's say, issues, but in the end MRI didn't show anything, and I personally was reluctant to MRI because I knew there wasn't going to be anything. It was way too generic. It didn't make sense. So non-specific pain is really important. Early degeneration. So patients that again have got probably mild arthritis, but they're coping. There's not really much point in going any further than an X-ray, let's say, because the patient's not going to do anything about it. Okay. And then overuse injuries. So tendon muscular issues where, again, clinical acumen tells you it's obvious what the issue is. Right, now choosing the right scan. So this is a very simple summary. So X-ray is obviously for bone, but very crucially for alignment as well. So for a knee surgeon like myself, the hip, knee, ankle axis is really important. So long leg alignment views are critical in lots of cases of cases that I deal with. And then in terms of osteoarthritis grading, well, obviously that's critical. In MRI is used for diagnosis of soft tissue injuries, menisci, ligaments, cartilage. I'm sure you're all aware of that. And then ultrasound for tendons and ligaments and muscles, and also for guiding injections within knees and for demonstrating an effusion. But also the first where they're dynamic, really important. So I had a patient in clinic today that had really interesting signs that presents basically his 12-year-old boy with lumps that appeared in the shin. One was 3 years ago, another tiny lump appeared 2 weeks ago. Clinical examination shows that it's muscle herniating through the fascia. But I could push the lumps in. It's like whack-a-mole. You push it in, it comes out later. You push it back in, it comes out. So that is only going to be apparent on dynamic scanning. The MRI is not going to help you that much unless it's a large muscle hernia that's coming through the fascia. So dynamic, I can't emphasize the importance of ultrasound in situations like that. So I've sent him for an ultrasound, and hopefully my diagnosis is correct. CT, I was mentioning before about complex cases, so I do lots of osteotomies and complex fracture fixation. So CT is critical for preoperative planning, and also I use customized jigs for osteotomy. So the CT then will go for 3D printing of customized jigs and sometimes even implants like plates. And CT is critical for rotational alignment. So if you're not sure, you put a knee replacement in the right way, is it, in terms of rotation, you can check the rotation of the hip, the knee, and the ankle, and determine that. That's something you can't get on conventional X-rays. So, any questions before we hit the case studies? Because I'm sure the questions are going to roll in now.
Yeah, there is a raised hand. So yeah, Naveed, do you have a question?
Yeah, thank you, Navid and Physio. I'd like to know about the reliability of this different scan as well. Thank you.
The reliability of the different scans. So that
yeah, in terms of diagnosis and imaging.
I mean, always we tend to say MRI is the gold standard, okay? Because there's lots of things that you'll see in the case studies which are missed on X-rays. So if you're again, give your clinical exam, your clinical acumen is really important, because if I can X-ray someone and be surprised, then I'll be like, okay, no, I know there's something in there, so I'll do an MRI, I'll escalate. So obviously the sensitivity for each thing differs according to what you're looking for. Okay, so grade 2 osteoarthritis is not going to be apparent on an X-ray very well, but on an MRI is going to be much clearer. So, but if you're looking for grade 4 osteoarthritis, then an X-ray is more than sufficient. You don't need to do an MRI. Okay, so it depends what you're looking at. And for example, a fractured neck of femur, most of the time it's clearly seen on an X-ray, but previously when I was training as a registrar, we'd then do a CT. But there is a small minority that aren't even visible on a CT scan, and you have to do then an MRI to show the bony edema where the fracture line is, but you will never see that on a CT or an X-ray. So it depends, but if the patient's, moving their hip really well and I'm examining it without any pain, then I won't escalate, made, X-ray and that's it. But if I'm sure, I will escalate CT and then MRI. So it's a very specific kind of way of doing it. Okay, so as I keep saying, it's all about the acumen. Your clinical acumen is really important to determine what you do next. Every scan has its role, and every scan has its own sensitivity and specificity for various problems.
Great, thanks for the question. There is one other one from Sarah in the chat, which is other examples where the dynamic look is really important.
Yeah. So clicking hip syndrome is a good example. So I don't know if many of you have heard of that, but basically it could be the iliopsoas tendon, which is clicking. It could be the labrum, and it could be the adductor tendons as they insert on the pelvis. So and it could be the IT band. Okay, so the IT band laterally. So often you try and examine these patients and you hear the click and you can almost feel the vibration somewhere around the hip, but you have no idea where. In an MRI, nothing's going to be apparent, but in an ultrasound where the radiologist has got the probe in his hand and patient's trying to elicit the click, it's great. It's great because the patient can actually move.
Great, thanks. That's it for questions. So I think on to the case studies.
All right. First one, sports injury. So I've given the answer here, but it's a 23-year-old footballer who twisted. This is very common. I'm sure everyone on this call has seen a patient with this. Felt and heard a pop, immediate pain and immediate swelling. And the examination, they come to clinic pretty early, quite a good footballer, so they're keen to get sorted quickly. And well, it's too swollen, too tender to make a real judgment, but it feels like there might be some ACL issues, maybe even some meniscal tears. And the patient then has an MRI, which confirms both an ACL rupture and a bucket handle tear. So what do? You'd refer on to basically to consider ACL reconstruction. Case 2, basketball injury, 16-year-old. And I've just seen a patient today with another basketball injury. It seems to be much more common now than it was. But this chap presented quite late, so over a year actually since the original injury. The usual thing you'd hear is, I didn't think much of it. It did swell up. It was painful, but I thought I'd get back within a few weeks. I did, but after a few months, and then it happened again. That's the kind of the history you'll get. And the examination shows basically a mild effusion, mild tenderness in both joint lines, and slight AP laxity. So this is where the interaction is. Hopefully no questions, just answers. So clinical suspicion, what are people thinking this could be? Maybe if you just kindly read out the...
Yeah, I'll just,
right.
so we have PCL, ACL, cruciate. So yeah, there's
Okay.
yeah, PCL injury.
Yep.
Osgood Schlatters is one, meniscus.
Okay, so less Osgood Schlatters, that's extra-articular. It's the bump on the tibial tuberosity. So we're talking about intra-articular things here because there's an effusion, tender in the joint lines. So well done to the people who've said menisci and cruciates, and particularly whoever mentioned PCL, because that's very good. Because here, I said slight AP laxity. I haven't said it's necessarily a positive anterior draw test. So most people are going down the ACL route, which is what's common is common, but it's very good to think outside the box. So if there's AP laxity here, then yes, it could be PCL. So that's great. Well done. These are the x-rays. Anyone see anything abnormal? Mostly not, right? Mostly not. Right. There's something I've kind of picked up over the years, which I don't think is a described phenomenon, but can you see the medial joint line? It's quite tight, well, tighter than the lateral side. Of course, there's still lots of joint space and there's no arthritis, but it's ever so slightly narrow. And when you see that in young patients, it often means there's a medial meniscus tear. Okay, so a very slight narrowing of the medial joint space in a young person isn't going to be arthritis. It's going to be a meniscal tear. And this is the MRI. Does anyone know what this sign is called? Can anyone see anything unusual on this scan?
So we have one slight patella tracking and medial limping, hook sign, Baker's. Yeah, those are three.
No double PCL sign. So at the back is a black structure that looks like a rainbow. That's the PCL. Okay, and that's fine. That's normal. But the one in front is not normal. There should, and that's why we call it a double PCL sign. The front black rainbow. Let's see. Let's see if I can point anyway. Annotate. Yeah. Okay. Does this annotation work?
Yes, we can see that.
Right. So the blue there is the medial meniscus, which is actually flipped inside the notch. So this is now a bucket handle tear of the medial meniscus, and it looks like a mirror image of the PCL, which is why it's called a double PCL sign. But of course, there's not two PCLs. This is the real PCL at the back, but what I've highlighted in blue is the flipped meniscal fragment. So this is a bucket handle tear. And this is another slice through the notch showing the lack of an ACL. Okay, so there should be a nice firm ACL in the middle of the notch there, and it's gone. So patient has sustained both an ACL and a bucket handle medial meniscal tear. So this is what it actually looks like on the scan. And I think it's really, the beauty of scan.com is when you order a scan, I can see the images. And that's really important, especially when you've got external, we always develop relationship within our own radiologists. So when it's reported by an external radiologist, it's really good that we have the ability to see what they're seeing and basically report it ourselves as well. So that is a huge advantage of ordering through scan.com. You actually see what the images of the patient you've ordered. So case 3, 69-year-old lady with hip pain, a year and a half. It's gone on quite a while, increasing and can no longer sleep on the affected side. The examination actually good range of motion in the hip with no pain, no internal external rotation is fine. There's no pain, but tender over the greater trochanter. So what are people thinking?
Trochanteric, oh, it's going so fast. Trochanteric bursitis, well, bursitis seems
Very
to be the
good.
one.
Well
Yeah,
done, guys.
gluteal
Well done,
tendon.
guys. Well done. Pretty obvious, right? So well done. And the key is you can't line that side. Okay. So when you've got intra-articular hip arthritis, you could often line that side. It's not that comfortable, but very classic of trochanteric bursitis because it's so superficial and the great trochanter pokes out so much that when you line that, it really hurts. It's a really good sign. So what imaging would people order for this patient?
So we have one ultrasound,
Okay.
ultrasound.
Lots of ultrasounds.
Yes, it seems to be
Any
the
any
dominant.
MRIs?
No, all
No, okay,
ultrasounds.
very interesting. All right, so
Oh, there is one now.
right, so that's interesting, and it's I think the audience is you know in as consultants we will often jump to MRI for things like this, but it's because we want to also know what's going inside the hip. So often there'll be a driver of bursitis. So actually, the first thing I would do for this patient is get an X-ray. So I'd just send them for an X-ray because if they've got severe arthritis, well, that's the true problem, really. The bursitis is a secondary consequence. If there's no arthritis or very minimal, then I would actually then straight away order an ultrasound guided injection into the bursa. So it's diagnosis and treatment simultaneously, trying to save the patient another visit. Um, if clinically it's really obvious, okay? Now, if a patient doesn't have much arthritis, but clinically there's lots of bursitis, but patient really doesn't want an injection, then an MRI is a great thing because you catch the joint itself to see how much cartilage is left there, because there may be more cartilage loss than the X-ray suggests. But at the same time, you're going to get a great image of the bursa. Okay, so again, it depends what the patient's looking for. Do they want it injected? Well, all in one go, then ultrasound guided injection. So
There are a couple of comments on this one.
mm,
So Anna says, question, but there's good range of motion. Um, there's also, so why X-ray? Yeah,
yeah,
when the range of motion is normal, why should we consider X-ray?
right, very good point. So she's 69. Likely she's going to have some articular wear. So I haven't told you how much rotation. So she might rotate 35 degrees each direction, not too bad. But it's still we're probably, like I say, spoiled that we always get an X-ray, but I would certainly do it at this age group, right? Because there is probably going to be some articular wear, and if you can't see it on X-ray, then, like I say, it will then determine whether you go straight to an ultrasound-guided injection to treat the symptoms, or do an MRI to further elucidate what's going on intra-articular. So, does that answer your question? It's an X-ray is simple, easy, and actually for us almost mandated for someone of this age. Okay, before then going on to ultrasound or MRI. It's quick and easy, it's cheap, and it should be done.
Yeah, there is one more which might be just interesting to collect. So Bob says so it says in sudden onset. So essentially, I think this means in the situation of sudden onset, is MRI used to check for glute tear and gradual onset ultrasound. I hope that makes sense. If it doesn't, we can get a bit more clarification. But
Okay, I think they're saying that what they're implying is okay. So gluteal tears are actually best seen on MRI, and especially if they're acute, because then you've got the edema to go with it. So it's really obvious. It's much harder, I think, on ultrasound. So it's a tricky one because obviously it's a muscle, and so muscles with ultrasound are as a dynamic scan, it could reveal lots as well. Personally, I would just go straight to MRI. I think it's gonna tell you even if it's chronic, you're gonna see a potential scarring where the tear was, or even still a tear. So the absence of edema means it's chronic, but you should still see some changes. So I personally, if I'm thinking gluteal tear, would just get an MRI.
so interestingly, there does seem to be a bit of a, I mean, controversy is probably too strong a word, but there's definitely a few of participants saying they don't think that this case needs any imaging. Treat before any imaging may not be necessary. Marina makes the point about discourage from doing unnecessary X-rays, obviously because of the radiation exposure. So, yeah, I don't know if you. Yes.
And this is what I mean. I think in hospitals we do get much more imaging than community physiotherapists who probably, to be honest with you, your acumen is probably better than ours. We have you see patients on a more regular basis. We might just see them once in a busy clinic and have 10, 20 minutes to assess. You know, you get to know them pretty well, don't you, after, you know, several sessions. And um, I think this is what I was saying about treatment. If the patient wants treatment, well, they're going to have some form of imaging. And if they want treatment, I would just do it in one go with an ultrasound guided injection. So symptomatic relief and diagnosis simultaneously. Whether you get an X-ray, if a patient isn't that, um, let's say, interested to know what degree of wear they have in the hip, and forget this example, I'm talking generically. You know, if a 69-year-old presents with hip pain like this, and the examination, you know, let's say is worse than this case, then it's good in my book to get a baseline, because sadly it's probably going to deteriorate, and sadly, as you all know, trochanteric bursitis could be recurrent. So for me, I would just send them down the corridor. If I'm in the community, probably wouldn't, like you're saying, I probably wouldn't. I'd just go straight to the treatment if that's what the patient wanted. And of course, I'm ignoring the fact that we've got lots of abductor strengthening to do and lots of physiotherapy. I'm approaching it from a purely clinical imaging point of view. Well, there's a ultrasound of a bursa. Now, as you all know, ultrasound is very radiographer dependent. Okay, so it's there's lots of you can't just look at an image and try and interpret it, because you're only seeing one slice out of, well, one snapshot of a very dynamic image. Okay. So case 4, 17-year-old girl, she falls on concrete. She's suddenly got a large effusion and anterior knee pain. What are the differentials here?
Fracture. We have patella fracture.
Very good.
Patella fracture.
Very good.
Yeah.
Nothing else? Goes back to my first
Suprapatellar bursitis.
bursitis.
Yeah, consensus does
Yeah,
seem to be
not
patella
really. Yeah,
fracture.
bursitis. I mean, again, it's extra articular. Again, she's got large effusion inside, so it's unlikely to be bursitis. Sounds like pretty nasty fall on concrete as well. So, anyone thinking cartilage? No?
Don't think we've had cartilage. We've got osteochondral, no
Yep.
PCL.
Yep,
But yeah,
osteochondral injuries. Yep, that counts. So exactly. So as I said earlier in the presentation, I see lots of children with lots of cartilage defects, lots of osteochondral defects, and this is actually a classic mechanism. So don't just think fracture. Think about that as well. So I'm sure everyone would start with an X-ray to rule out a fracture of the patella. Does anyone see any issues with this X-ray? Any problems?
a tibial kind of tuberosity.
Yeah, that hasn't fused yet. So yeah, that hasn't fused yet. Good spot, but that's not relevant to her injury. Anything more north?
There's a patella alta.
It's not that bad. No, I mean I can't measure it here, but doesn't look. No, it looks okay. Looks okay.
Medial aspect narrowing adulation.
Okay, yeah. So medial, yeah, good. So it could be a medial meniscus there, yeah, according to my previous philosophy. But won't give you a large effusion, not immediately, and kind of she's complaining of anterior knee pain.
I
Does
think
anyone?
there's a couple saying above, there's a loose body
Yes, very
suprapatella
good.
above the patella. Yeah.
Well done, guys. Well done. You found it. Right. So there's a small loose body just north of the patella. Okay. So about 2 o'clock, small loose body. So that's it. Very easy to miss, correct? Very easy, especially in a busy A&E department. No fracture, out, done. But actually, you do an MRI and look how big it is, right? So what you're seeing on the X-ray is just the bony bit. You're not seeing the cartilage that's come off with it. And in kids, that cartilage could be pretty large and definitely needs to be put back sooner rather than later. So this is a case again where, you know, you've got a kid who's, you know, being, you know, being honest, it's painful and the knee is massively swollen. There's no fracture. You've got to think of something else. And either it could be an ACL injury, it could be an osteochondral defect. So get an MRI, and then and I do tend to see a lot of these and fix them. And we basically put them back with screws. I don't use metal screws. I use plastic, very tiny bioabsorbable screws, which go into the cartilage. So this is a cartilage island being pinned back. And that's critical in someone her age, 17. It will, without that, she could potentially have a partial knee replacement within, 10, 15 years. So pretty disastrous if you don't put it back and detect it. So really important to, as I said, to escalate to MRI if required. That's right. So case 5. So we've got a 70-year-old lady, bilateral knee pains. It's gone on for several years, but now the left is worse than the right. You would all get an X-ray, hopefully, if you've managed conservatively as much as you can in the community, and still things aren't improving, you'd get an X-ray, and whoa, you'd probably hopefully detected the valgus deformity clinically. Anyway, and you can see how severe this is. But you'd be surprised at how many patients like this get sent straight for MRI without an X-ray. So I hope nobody would MRI this knee. It's pretty obvious what's going on in the X-ray. So this is to say, yes, look at the patient's alignment. If it's way out, an X-ray is indicated, and therefore an MRI is not necessary thereafter.
I think Amy probably sums that up by saying crikey. There's a lot of other OA knee
Oh yeah,
X-ray. Yeah.
absolutely. Look at the patella. Some of these are almost auto-fused. It's really bad, but it's so satisfying to give them a knee replacement. So satisfying that they wake up with a straight leg, and these are the most grateful patients. Case 6, 48-year-old man, 2 weeks knee pain without any trauma. Examination isn't much except small scars around the knee. Now, yes, from my memory, this chap couldn't speak English very well, so it wasn't clear as to what had happened before, but sounded like he had previous surgery abroad, but certainly couldn't tell me what that was. But he's now suffering in pain, but it's only 2 weeks, so I'll go straight into it. There's no point beating about the bush. You really want to know what's happened previously, and I get it. It's only 2 weeks, and you may just want to pursue a conservative path, especially without trauma. But I think at that age, you want to know what's been done before, and so an X-ray, as you know, I love my X-rays to begin with, and this is the reason why. You can immediately see a staple. You can immediately see a tunnel in the tibia, which is consistent with an ACL reconstruction. So this chap has had an ACL reconstruction in earlier life. And you can also see here that the joint spaces aren't amazing for his age. They're quite narrow, and you can see a bit of fluff on the sides there. Osteophytes, maybe a bit of chondrocalcinosis. Something is going on there. So he's got a bit of a degenerative joint for someone of his age. And I would then decide on, right, now I figured out what surgery you've had, and you've got basically early degeneration. I would then go down that path of, well, I know if I MRI that, I'm going to get meniscal tears and potentially an old graft rupture, an old ACL graft rupture. What will I do about it? Is he already so stiff that we're not going to contemplate revision surgery? Is he already so worn that revision ACL reconstruction isn't going to benefit him? And therefore, we're in the osteoarthritis pathway, in which case there's no point MRIing. But if the pain isn't the pain is sufficient to warrant injection therapy, for example, then I would get an MRI to know exactly what grade of osteoarthritis he has. Okay, so that's what the mental processes that I would go through.
There was definitely some very definitive they would scan in this instance, just in the chat.
Definitive what? Oh, so to
Saying they would scan in this, in that instance,
Yeah, exactly. So, but again, you can see why an X-ray is important, okay? You'll detect it on an MRI, but for us, it's so nice just to see an X-ray to see how much wear. MRI obviously will tell you how much wear, but there's just something about an X-ray which I'm sure many of you will appreciate by having that as a snapshot on record as well for the future. Case 7, 74-year-old lady with bilateral groin pain, severe, but also mild to moderate back pain. So what modality of imaging do you think would suit her, and of what? And again, I'm assuming she's been in the community, had physiotherapy, conservative treatment hasn't failed and we've escalated now to someone like myself in clinic?
MRI L spine, Tim
Yeah.
suggests.
Yep.
Bilateral hip X-ray.
Very good.
X-ray
Very good.
pelvis, XR hips, pelvic scan, MRI hips, lumbar, hip
Yep.
joint X-ray.
Yep. So personally, I would get a lumbar MRI because it's going to tell, because of course it can refer to both hips, okay? But this is severe groin pain, which is more classic for intra-articular hip pathology. If it was in the back or buttocks or even, side of the thigh, you could argue it could be radiation from the spine, but this is groin pain. So 100%, I'm going to send her for an X-ray, AP pelvis, bilateral, hip lateral X-rays, and then take it from there. And the history here is very clearly that of osteoarthritis as well. So that's my process. I would get an MRI lumbar spine, but I would X-ray the hips and take it from there.
Yeah, we've definitely had a few exactly the same. Julie, X-ray, L spine, hip first, had a few of those.
Good. I'm so glad to hear, because you again, you'll be surprised how many MRI hips are being done without an X-ray. And this is her X-ray. There's no need to MRI her hips. It's severely arthritic on the right and moderately arthritic on the left. So the arthritis is significant enough. I don't need to do an MRI scan of the hips, but we do of the lumbar spine. And you can see there's been previous instrumentation of the lumbar spine here. So hopefully that would have come out in the history. So if you were going to order a lumbar MRI, you'd make it very clear that the patient has already had metalwork put in the spine, because they can then do a metal artifact reduction sequence, a MARS MRI scan, to try and help reduce the artifact from all that metal. Okay, so really important. The more information you give the radiologists on the request for your scan, the more accurate your result's going to be, because they might not detect a scar in the back, or they know the history of, and so it's your job to basically inform them and get them and kind of guide them towards the correct form of MRI, which is in this case a Mars MRI of the lumbar spine. So yes, this is before hip replacement and after I've replaced her hip. So happy customer. Obviously, the left side is arthritic and painful, and probably is going to become more painful after the right hip replacement because of A, offloading, B, we've got rid of the pain on the worst side, and now the distraction is gone, and the left hip will probably become more painful. So, and I can't remember what her MRI spine showed, but in the end, it was more hip focused because of the groin pain. So case 8, 17-year-old playing netball and felt kneecap pop, immediate effusion and pain. What are people thinking?
Yeah.
Lots of dislocations, subluxations, MPFL, absolutely. Cartilage injury, well done. Now we're thinking cartilage injury, not just bone injury, so well done. Great. Lots of people talking about patella stuff, which is exactly what we're getting at. So, and modality. So what we're going to do? What modality we're going to order? Yeah, good. Yeah, exactly. I wouldn't beat about the bush with this. I would get an X-ray and then straight away get an MRI, because it sounds like it's either going to be a cartilage issue or ACL issue, or something. It's really unusual to get patella fractures in children, or even in young adults. It's much more common in later life. So we're talking much more cartilage, soft tissue, ACL kind of injuries. So very low threshold for MRI, but again, you know me, I'm going to get an X-ray as well. So you can see this is an axial view of the MRI on the left. Here is an axial view showing the patella is subluxed laterally. It's kind of perched on the edge of the lateral condyle. And you can see evidence of bruising and bone edema laterally in the femur, and also medially in the patella. And that is what we call a kissing lesion. So when that kneecap was out, that medial facet of the patella was actually hitting the lateral side of that femur. So what you're seeing now is not what happened at the time. The time that patella was completely out and it was sitting. So the two bony edemas, the high signal, the white signal, were actually touching each other. And sadly, you can see the consequence, a huge patella osteochondral defect. So on the patella, you can see the patella thickness on the right side, which is gray, dark blacky, icing on the cake. I tell patients, imagine the patella is like a chocolate cake. You've got a lighter gray film on it, like marzipan, which basically should stretch across the whole amount. But you can see on the left side of the patella there, which is the medial facet, it's all white and absent. So there's a huge patella osteochondral defect there. And you can see why. The trochlear is really flat, so the V-shaped groove in which the patella sits should be far deeper. That is trochlear dysplasia with patella dislocation. And there's me doing an MPFL reconstruction on the right side. So it's where we use X-ray. That wire is finding Schott's point on the femur, where I'm basically going to tie a tape between the medial epicondyle and the medial side of the patella to hold it back. And it's a very, very rewarding operation. I can't tell you how many kids sadly get passed around so much. People think there's nothing you can do to stabilize a patella for some reason, but no, you certainly can. And there's no point waiting until they knock off a huge bit of cartilage. Normally I say it's 3 strikes and you're out. But often patients will present with an osteochondral defect, and as I'm pinning back the osteochondral defect, I'm certainly going to stabilize the patella. And they love the operation so much, they feel they've got their confidence back. This kind of, let's say, disease of subluxation, they fear sport, they fear doing things at PE in school, they fear they can't, they've got such patella apprehension. And so much so when they stabilize this knee, often they'll beg for the other side to be done, even though there's no dislocation. So which puts us in a difficult clinical situation when nothing bad has happened yet, but they want that confidence again to go back to full sport. So is there age restriction to fix the patella that dislocates? No. I've actually used it in a knee replacement setting in a very old patient where the knee cap for many years was subluxing and tracking badly. Actually, one of the causes of patella cartilage loss is maltracking of the patella. So of course VMO exercises, of course do lots of physio. But if it's still subluxing, there's no point waiting till they wear off the back of the patella. So no, there is no contraindication in terms of age.
Hannah also just had a quick question. Why would you do both X-ray and MRI for patella dislocation?
Why an X-ray and MRI? Right. Oh, so you can see here this would look normal. This patella would look normal on an X-ray. You can't tell that defect on the medial facet, the white. I'm going to try and annotate again. So I'm talking about this is the missing cartilage. Yeah, can you see that, Tom? The blue circle.
Yes,
that is the missing cartilage. You're not going to see that on an X-ray. So the X-ray will look normal. So I would definitely get an MRI in addition. Yes. So that is actually really common. I think if the majority here are physiotherapists, you'll be very, very familiar with this, right? Very familiar. And I honestly believe in this country, MPFL reconstruction is an underutilized surgery. There's lots of operations we can do to stabilize the patella, depending on the originating problem. But a tibial tuberosity transfer or a trochleoplasty to deepen the V-shaped groove are all options, but they're much more invasive than just an MPFL, which I actually tunnel the tape below. The 2 tiny incisions, one for the kneecap, one for the femur, and then we tunnel the tape in between. So if I go back to, yep. Does fixing the medial ligament to better track the patella reduce chance of? Yes, absolutely. So if the patient's maltracking and they're eroding the lateral facet of the patella, you bringing it back and stopping that friction certainly helps. Certainly does. So case 9, 59-year-old, what is the up call? Talking very fast. Oh, I'm sorry, I do talk fast. And especially, I'm assuming it's kind of medical audience, which of course, MPFL, medial, patella, femoral ligament reconstruction, MPFL ligament reconstruction. So that's native. We all have an MPFL, but it's often attenuated after the first dislocation or even ruptured or torn, and it never really assumes its normal length again. And therefore, sadly, the incidence, the incidence of recurrence is really quite high for patella redislocating. And as you probably already know, the younger a patient has their first dislocation, the more likely it's going to happen. So sadly, a 10-year-old dislocating is almost guaranteed to have more. So I wouldn't wait really for the second or third. I would stabilize early. Whereas a 19-year-old, first dislocation, traumatic, not, enough trauma, I'd give them a chance. I wouldn't rush to do the MPFL reconstruction. So those are the three strikes in your out group I'm talking about. But certainly the younger you are, the more chance of recurrence, sadly. Right. So, right. I hope, well, you probably saw that 59-year-old lady, long-standing anterior bilateral knee pain. We're always going to start with X-ray. And what's happened on the left knee? Anyone? What operation has been done before on the left knee? Yeah, ACL reconstruction, so you know by now. And these are the laterals. So yeah, in terms of arthritis, yeah, I mean, this is basically very similar to the X-ray we saw before, but you can see the osteophyte here is quite a bit bigger. So we've got probably even more degeneration than we had in the last patient. But there's bilateral knee pain. So, this doesn't look too bad, certainly much smoother. Yes, reduced joint space, but because it's bilateral and, it's not specifically the left, I got an MRI and saw the back of the patella, which again, you can't see that well. Well, you can't see the cartilage at all on the X-ray. Sometimes, obviously, if it's really bad, you can get reduced joint space on a skyline X-ray of the knee. So looking at the axials here, you can see the amount of cartilage lost behind the patella. Again, this is what the cartilage should look like, but even that's thin, right? So you can see it's absent here. And in fact, you've got where I put the second annotation, there's bone edema. That white means that the force is being translated directly to bone, which means it's completely exposed bone at that point. So actually, patient has severe osteoarthritis behind the kneecaps and is bilateral. So actually, it wasn't really the pain was coming from the previous ACL reconstruction, which may have failed and given instability and then arthritis later on. It could just be a separate thing. So here, MRI actually was really quite useful. Right, case 10, 69-year-old, previous left knee replacement 20 years ago. Did pretty well, 20 years. So she was 49 when she first had it. And now it's painful, unfortunately, for the last year. So what's the diagnosis people are thinking? And I think we'll make it the last one so we can take the questions from the previous questions, to be fair to those who have asked previously. Implant loosening, very good failing prosthesis, requiring revision. Absolutely, you got it. Well done, guys. So first you do an X-ray. In fact, there's bilateral TKRs. It's the left one. And actually here, it looks good. It looks like it was just put in. So I personally don't like this type of prosthesis. It's fallen out of favor. It's not used these days, but you can see why. The tibial pegs are very close to the edge of the tibial bone. But the X-rays look fine. So next stage, what would be the next step? I mean, we would do blood tests to look for infection and various things like that. But what imaging would you do next? MRI, not really. MRI, there's going to be, even within Mars MRI, is going to be too much artifact to tell if it's loose. CT, yeah, very good CT. X-ray we've done. So CT, yeah. So CT, it will probably show you if it's quite loose, but not if it's a little loose. So no one's got this one yet, but it's probably because I haven't mentioned it as a modality yet. CT disease activity. Oh yeah, we're getting there. CT disease activity is, by the way, the lateral. Again, looking really nice. Looks like it was put in yesterday. So PET scan, someone said, that's very good. This is the closest thing we tend to use in orthopedics to a PET scan, which is basically a CT PET, right? So it's a CT with an overlay, the nuclear medicine injection absorption into high bony uptake areas. Okay, so a PET CT is very useful in this situation because it does show you areas of increased uptake. Things that aren't detected on a CT or X-ray, you will tend to see here. And then if it's increased in the initial blood pool phase, then it could be more like infection. If there's nothing in the blood pool phase and it's in a later delayed phase, then it's just aseptic loosening. So it can often help, not completely be definitive. You know, many skeptics about this form of modality, but I think in a case where the X-ray is normal like that, it's really quite helpful. Right. So I think, yes, to be fair to those who have asked and those who want to ask further questions, please go ahead. And I've got the chat. So if I look at the chat, do you mind, Tom, looking at the question and answers box? Yep. Should PET be used more in PFJ, S meaning syndrome, I guess. Is that right? PFJ syndrome. That's a good question. We don't do that. We don't use it, but it does make sense because you're looking at the pressure between the patella and the trochlea. And interestingly, a patient who's had a knee replacement without the patella having been resurfaced, you'll see lots of those, I'm sure. You know, I'm you know, the surgical camp is in two very much divided camps on this. I'm a replacer. I will often almost always replace the back of a kneecap if I'm doing a knee replacement, but 50% of the knee surgeons will not. And so in those situations where the patient complains of anterior knee pain, we actually do a PET CT looking at the at exactly what you're alluding to there, an increased uptake between the two articulating surfaces, and then actually go on to resurface the patella in those cases. So why do we not use it in the normal the PFJ syndrome population? Probably because we've got enough evidence on clinical examination and MRI. We don't need to then go for, you know, a more expensive, more involved scan. I think most of the time these patients that you know, young flexible teenagers, particularly girls who've got hypermobile patellae, who have got pain, they start to get chondromalacia patella and then more wear. It kind of fits, and then you get an MRI showing, you know, subluxation, possible even articular wear. We don't really need to then proceed to a PET CT. But like I say, it's particularly more used in the knee replacement setting for loosening or seeing whether you need to resurface a patella that hasn't been resurfaced. Hospitals are reluctant to X-ray. Yeah, you know, can you just expand on that a bit? Because it is, if you justify it well enough in the request, they really shouldn't be doing that. But I've had a second patient today see me privately because unfortunately the ultrasound got rejected through the NHS. And last week I saw a patient who was worried about cancer. It was a lipoma, basically on the back. And they again rejected the referral, even though there was a strong history of cancer in the family, and all she needed was reassurance. So I have to justify, you know, requests specifically for ultrasound where I work more than X-ray. X-rays, I never really get any rejections. So I'd be interested to know why they're reluctant to X-ray.
Maybe so it's Julie who well, asked that or mentioned that. I wonder, Julie, if I unmute you, it might be interesting to hear your thoughts on that.
Yeah, we kind of have an agreement with the local hospital for my husband, who's a chiropractor, to refer for X-rays. And we also have a contract with the local hospital for MRI referrals. No issue with MRIs with our kind of description of the condition, very accurately put down. But X-rays, they just seem very, very reluctant. Generally, we're referring for people who've had falls, traumas, suspected arthritis with a view to needing a hip replacement due to very, you know, considerable restriction on their quality of life and pain and inability to carry on without strong painkillers and lack of sleep, etc., etc. Mostly these are old people when we're referring for the hips, but they are generally thrown out. They're not very keen in the X-ray department, but if you go through A&E, you'll get one.
That's exactly right. Thank you, Julie. That's exactly what I was talking about earlier. It's far easier when you're there, but also far easier if they were in front of the patient, which they're not. And that's what I don't appreciate. It does annoy me. I'm sure it annoys you as well. When you know it's clinically indicated, I mean, there has to be an element of trust, isn't there? And they have to start trusting, especially when you're local and they probably know your name through the MRI request and all that. So it's not fair. It's not right. Like I said, I've had 2 patients in the last week see me privately because they had their ultrasound request rejected, and they were completely legitimate. In fact, the kid I alluded to earlier that I saw today with the muscle herniation, his ultrasound was rejected. What did I do? I ordered an ultrasound. So, I mean, it's just ridiculous. It wastes time. It's not good for patient care. It's unnecessary. The level of radiation in an X-ray of the hip is so minimal that it's gone a bit too far, I think, personally. Of course, there's going to be one or two people around the country who are ordering, prematurely and without good justification. But everything you've said makes me trust you 100%. So, and they should. I'm sorry that you have to go through that.
Thank you.
And
Thanks, Julie.
thank you, Julie. Hospitals are views on Lars. Very good question. So I have started doing synthetic ACL reconstruction. So this obviously it was in vogue many years ago, and it came out of vogue because they were carbon fiber and they caused problems. But actually, the modern Lars and Leeds Kio ligament, which is now called Kiros, Xiros, are much better, and they're safe. And I think they're going to have an increasing role in the future for ACL reconstruction. So I think that's a great question. I will often still use hamstring and quads, but because there's also a cost element, especially for patients paying privately, for example, or even the NHS in terms of synthetic ligaments, but it will reduce the donor site mobility. So rather than take their hamstrings or quadriceps, I would just put a synthetic graft. So my eye is firmly on the research there, and that's why I've actually started to do that for my patients, especially when they ask about the options. Recommendation of timing of imaging when suspecting ACL rupture. Right, good. Again, great question. Again, it depends. So if you've got a 45-year-old who's got 6 kids and is an accountant and doesn't do much sport, I'd delay it, because even if it's ruptured, you're not going to do much. You need to do an ACL specific rehab program. Okay, so I would refer them or if you are the physio, do an ACL specific rehab program if you're pretty sure that's what it is. If you're not sure, then fine. I mean, MRI, it's going to help you know. But if clinically it's really obvious, but the patient doesn't suit an operation, then there's not much point. But most of the time, you are going to be MRI, because most of the time they're young, they've sustained it through football or basketball or whatever, and you want to know early. So and there's no rush for an ACL. I don't rush to do an ACL reconstruction. They must regain full range of motion before I do an ACL on them. What the rush is to determine if they've got any meniscal tears, which is going to get worse. So if they've got a bucket handle tear, I'm much more keen to go in and fix that quickly before it macerates and becomes unfixable. So I intervene early for bad meniscal tears to prevent extension, because I repair almost every meniscus tear that I see. So I'm a bit too OCD with meniscal repair, but that's one indication for an early scan if you're querying an ACL. An ACL on its own isn't much of a rush. Often reject. Oh yeah. So ultrasound for knee for suspected Baker's cyst gets rejected. Okay, that's a great question. I'll tell you why. Ideally, if someone has a fall and is strongly suspected of a fracture, patients are advised to go to A&E for early recognition and early appropriate treatment. Okay, of course, that's true. But sometimes patients present after a few days, and the clinical suspicion for themselves wasn't huge. So. But regarding the ultrasound for Baker's cyst, right? So I would actually agree with a rejection of that potentially. Okay, why? Because the Baker's cyst is a symptom of is not the problem. The Baker's cyst isn't the problem. What's generating the Baker's cyst is the problem. And so what you have to do is find out what generated the Baker's cyst, and ultrasound is not going to help you with that. So it's an X-ray and MRI. That's what's going to help you know why the Baker's cyst is there. Because even if you decompress the Baker's cyst, it's going to come back straight away unless you address the underlying problem. So an ultrasound simply for a Baker's cyst is not warranted. The only time I have ordered an ultrasound for a Baker's cyst was for someone who I've scoped, and I've dressed the meniscus tear, and I drained the cyst, and very slowly it came back, which I'm probably because there was a tiny neck which was communicating the capsule with the Baker's cyst. And I asked for the radiologist to aspirate it under ultrasound guidance and inject steroid as a sclerosant, so it sticks the walls together and doesn't come back. Okay, so very rare. I've only probably done that once in 8 years as a consultant. So I wouldn't personally, ultrasound a Baker's cyst. Sorry about that. Samina, rejection might be not proper reasoning for scan. Yes, but Julie did say that she does type in lots of information, which is great. So I have to say, so do I. And sometimes you still get kickback. But you then explain it further and they seem to accept it. Is there such a thing as a cartilage replacement operation? Another great questions, Tom. So cartilage, so if I've got a defect and I've got a young patient with a piece of cartilage that's flown off, I will pin that cartilage back. There is nothing on this planet as good as that patient's own cartilage. So you pin it back if and when you can. If it's fragmented into so many small pieces and you can't pin it back, I try and fill the gap. How do I fill the gap? I do a very modern technique from Switzerland called auto cartilage. So I use a shaver to debride the edge to make it a nice smooth edge rather than the often ragged and stellate edge of the defect. That cartilage doesn't go in a bin, it gets caught in a little basket. And then it becomes very small pieces, which we then combine with PRP from the patient's blood and pack the defect. It's a fun operation and it works beautifully. And it's a really, really good way to restore that native cartilage, because what did we do before this modern technique? It was microfracture, make lots of tiny holes in the bone, encourage new blood to come and fill the gap, and then that gets converted to fibrocartilage, which is not as good as the patient's own hyaline cartilage, which is why I prefer autocart in those situations. But you can't just, that's for defects. If a patient's got arthritis and the whole field is worn, you can't pour cells or the small fragments of cartilage into, it's not going to work. So that's why knee replacement, unfortunately, is still a very valid option in those patients. So you can't bring back the whole field, but you can certainly fill in a patch of grass, if that makes sense. There seems to be a discrepancy. GPs and physios are discouraged to refer for X-ray, but specialists in hospitals seem to have very low threshold for. Absolutely, this is exactly what we were alluding to before. I'm spoiled. That's the bottom line. We as clinicians in hospitals are spoiled, and I think I would probably encourage a bit more X-rays in the physiotherapy world, as long as they don't get rejected, as Julie was saying earlier. But there's a balance to be struck, and I think as long as if X-rays are being rejected, then get an MRI. But in some cases, it's kind of unnecessary escalation. I think it's usually because someone at tertiary care is. I think it's because someone at tertiary care. So I'll read this aloud. Sorry for those who aren't reading this. I think it is usually because somebody at a tertiary care center is assumed to have tried conservative management or has initial advice from primary care practitioners. Potentially, yeah, it could be. It could be. I also think it's ease of access. I think and relationships. They know me. I'm the consultant who's worked there for 8 years. It's another El-Tawil patient, so we'll just do it. So, but that's a potential reason. Thank you, Sarah. Thank you. You have spoken such sense this evening. You have restored my faith in. Oh, bless you. That's very kind, Catherine. Our local NHS are quite remiss and tend only to look at the bit that hurts rather than to consider it. Absolutely. No, this is absolutely true, Catherine. So we're always told, aren't we? Treat the patient. Not the knee or even the scan. And it is absolutely crucial. And this is the bedside manner. You have to speak at patient level and just make sense. And patients appreciate it. And thankfully, in 20 years, I've not had one complaint, and it's because I speak like this to my patients, okay? And they understand, and I show them the scan, and they understand. So that's very kind. Thank you. Gratitude from Canada, Stephanie. Thank you. Very nice. You've been scan.com and Rehab Guru. Well done.
Yeah, global audience.
That's very kind. There's lots of nice.
Yeah, thank you. Lots of amazing comments there. And I think we do have a few questions left in that Q&A, but I think we'll try and, if that's all right, we can follow up afterwards.
Yeah, although there's one that I have to answer, Tom. I'm really sorry.
Okay, yeah, go for it.
What are your thoughts on development of genicular artery embolization as a midpoint prior to total knee replacement? I know it's not the subject of tonight, but it's still a great question. So, because absolutely, many people will not have heard of this. There's lots of my colleagues haven't heard of this. I've referred 2 patients for this and it's worked. So it's obviously, so you've got a patient who's got severe knee arthritis. You really want to do a knee replacement, but you can't because they're so comorbid. They've had, 10 strokes, 20 heart attacks. They've had bypass surgery. You can't do a knee replacement safely on them. Those are great candidates for that. I feel so sorry for those patients who are disabled for the rest of their life in a wheelchair, in pain, in agony, because we go, you're not fit for a knee replacement, bye. It's not fair. So that is a great option for those patients. So is arthrosamid, which is a very recent injection that's come out. You know, I don't know if people have heard of it, but you know, I've started doing that. Hugely beneficial in that kind of population, or even in the young who aren't, they're too young for a knee replacement. So those two options are great in that population. So sorry, Tom, but I had to answer that.
No, of course. Yeah, yeah.
And thank you so much, everyone, for the kind comments. It's very kind. Thank you.
Yeah. With that said, I'd like to say a massive thank you to everyone here. As you've seen, there's been tons of amazing participation, engagement, lots of super interesting questions, and I think they're still coming in, and we could probably go all night. But I think we will have to wrap it up there. And finally, I just say a huge thank you to Mr. Sherif El-Tawil for amazing insight and value-packed presentation. So thank you so much. And have a great evening, everyone.
Yeah, and thank you, Tom, and thank you, Simon. Great day. And thank you, audience, for being so engaging. That's been really great. Thank you. I've enjoyed it.